Hello viewers, my name is Tuyeimo Haidula and I am bringing you a documentary on comprehensive sexual reproductive rights in Southern Africa. The documentary will look at 3 countries, that is Namibia, Botswana, and South Africa. I take you on a tour on what happens in 2 of Namibia's biggest hospitals, Katutura and Windhoek Central Gynae wards, and how our healthcare workers offer the much-needed support to the patients. The nurses talk about cases of botched abortion, which are also presented at the hospital. Many a times, the question remains, why are these women seeking for these services? What has government not done prior? I pursue this story to identify and prioritize needs and potential follow-up actions related to critical sexual and reproductive health issues, specifically the reduction of unintended and unwanted pregnancies, the unmet need for contraception, morbidity and mortality related to the unsafe termination of pregnancy, and the integration of HIV and sexual and gender-based violence. I pursue this story to look at areas where Namibia can improve on health for all and gender equality, and the African Union's Agenda 2063 to improving sexual and reproductive health in Africa, particularly among adolescent girls and youth women. The African Union's Maputo Protocol, the protocol to the African Charter on Human and People's Rights on the Rights of Women in Africa, is the only human rights instrument with prescriptive language on abortion criteria, and estimates that the Maputo Protocol contributed to countries' reforms that added legal grounds regarding abortion since its adoption in 2003. I pursue this story for a young woman out there who might have accidentally fallen pregnant, a victim of rape, or women who may find themselves unexpectedly pregnant and very scared to know that they too can have an abortion and that life and football will go on. I've spoken to industry experts on the issues of comprehensive sexual reproductive rights, including our former First Lady, Monica Geingoes. They all carry a strong message of advocacy based on the evidence of the impacts of sexual and reproductive health and rights issues. There's a call for the need to delay sexual activities in young people and provide greater care for the women, youth, and adolescents, rights for control and free decision-making on matters related to their sexuality. Maria is now a beauty therapist, a retired sex worker. She aborted when she was 32 years old. She is now 39, turning 40. She had just separated from her husband for a year, and she had 3 younger children. She was also not sure who fathered her pregnancy and the relationship status, if at all. So termination was the only way out for her. She scrolled for numbers on social media and found a seller who sold her 4 pills, but it didn't work. She called the seller again and she was informed she needed a double dosage. Maria paid and waited. Maria's nightmare began when the pain was excruciating. She had no choice but to seek medical care at a private hospital. There she laid out her truth and she told the nurse on duty what she had done. She was later to discover that she was pregnant with twins.
First I was prepared. I had made a choice, which was circumstantial then, that I'm going to have this abortion. But the moment I learned that I was actually carrying double, 2 babies, that really hit me so hard. I felt like I just wish I could turn back the hands of time. It really, it really hit me so hard.
My name is Sister Mujanima. I'm a gynecologist nurse. Welcome to 2 West. This is a gynecology department. This is our procedure room. We usually conduct MVA. MVA stands for manual vacuum aspiration. So this is where the doctor conducts the procedure. They remove the retained product of conception. We have our syringes here, and then down on the trolley we have vacuolators. Sometimes our patient goes in PPH, or let me say, for instance, if a patient starts losing so much blood, we have to put up IV lines just to just for them to be stable. Okay, and then here we also have syringes and then cannulas also. And then we have our lignocaine. We use the lignocaine for cell block. When the patient, when the doctor is removing retained products, the patient goes through so much pain. So they have to inject lignocaine there just for to numb the muscles so that the patient cannot feel so much pain. If you check this side, this is where the patient lie. They lie on their supine, and then they put their legs here so that they can open up nicely so that the doctor can be able to conduct the procedure. There is our sonar machine. The doctors will always make sure after conducting the procedure, they have to use the sonar machine just to check if there is any retained product that are left after the procedure. So before procedure, they have to use the sonar machine to check the retained product. After the procedure again, they have to use the sonar machine just to check the retained product if there is any left. So this is where some of our instruments, the instruments that need to be sterilized, they are in this pack. So every pack will only be used by one patient. If they are done, then they have to take it back for sterilization. This is just for light. Okay, so we have 3 basins there, those boxes there that you can see. They have instrument, but they have different water in it. Instrument, when the doctor is done using a certain instrument, they have to rinse it. After rinsing, and then they have to put it in Sidex.
Sister Mujanima explains that the cases of abortion recorded at the hospital depends on seasons, and they have a roster which they share with Katutura State Hospital.
We have a roster for admission, of which we share with Katutura Hospital. So there are days, there's a roster already with dates and the ward admitting for that certain day. So whenever sometimes you will receive round about 2 patients, sometimes you receive maybe 6 or 8 patients. It depends day by day. But in most cases, when, let me say, for instance, it's December, like March, February, we are expecting a higher number of patients that are coming in with an incomplete miscarriages or inevitable miscarriage, whatever kind of miscarriages. I don't know why. Maybe it's because of festive seasons, but like mid-year, you hardly get a lot of number of these cases, but maximum number that we can get, they can go around until 12 or 10 per day.
In the past, doctors and nurses first needed to report a suspected botched abortion before they could offer help. But as lives are at risk, healthcare workers now prioritize saving the women seeking medical services. Sister Mujanima explains in which instances police are informed.
It doesn't happen more often because, it's not the responsibility of the doctors to call the police. For them, they only treat. They give the proper treatment that the patient needs. But we encounter cases where, let me say, a patient comes in with a height of fundus that is 28. There will be questions that why this big tummy, but there is no baby, no placenta, nothing. In such cases, you find some doctors, yes, they will involve the police. Some they will involve probably social worker, and then social worker will take it until gender. Like, let me say, for instance, it's just an example. Like last year, we got a teenager that came in with No, she didn't come in with a placenta, but the tummy was so big. You can literally see that maybe this is 32 weeks. This was 32 weeks, but there was no baby, there was no placenta. So the doctor has to question and question, but we didn't get any answer from that patient. So what the doctor did is involve social worker, involve the psychologist, and later on involve um, the police officers. But we hardly get these cases because for them is to treat. Even if they say this is an illegal abortion, it's not it's not up to, I mean, it's not really a case, you understand? Because for them they focus more on treatment than these legal documents and all that.
The doctors and nurses explain that patients who come in with incomplete miscarriages and have suspected cases of botched abortion are encouraged to take family planning after the procedure. But how open are these women to using family planning?
Family planning wise, we are fine. Yeah? We almost have every type of family planning. But the challenge that we are getting now, like in the gynae department, is most of the patients, they don't want family planning. Okay, we try to explain, we try to give health education, because you find out that somebody doesn't want family planning because of whatever other people have said in the community, the way they understand it. We try to give health education, the benefit of family planning, but still, majority of our patients, they don't prefer family planning at all. Because we prefer, before discharge of this type of patients, at least every patient that we are discharging should be on family planning. But you'll find out, like, in a 50% of patients that you are discharging per day, it will only be maybe 10% of patients that will get family planning. We have a challenge, a very big one.
It is on the eve of Valentine's Day. I am at Windhoek Central Hospital Gynae Ward. Health Ministry Executive Director Ben Nangobe has given me permission to film inside the hospital. Consent should be obtained from the healthcare workers and the patients themselves. The nurse on duty tells me they've made some admissions the previous night and this morning for incomplete miscarriages. One patient was being prepared to go to the manual vacuum aspiration room for cleaning. She was evidently in pain for the news crew to approach her for filming.
So, when I went there, I had to wait for the doctor until 11 o'clock. That's when I went back home. So, I was bleeding. Then I had to go to the sauna, and she told me that the baby was fine. So that eventually the bleeding would stop. Then I went home. It stopped, but then started again. That's why I had to go back last night.
And then when you went back, what happened?
When I went back, then I got help. The doctor examined me, and I'm here.
They sent you to Windhoek Central.
Oops. Okay. How far along was your pregnancy?
Just a month.
Okay.
Is this your first baby or do you have?
I had 3 babies, but I had a miscarriage before.
Okay.
Starts in 2022.
Mm-hmm. I'm so sorry to hear that. How old is your last boy?
Mine,
Your last one?
she's 6 weeks long.
No. Boy or girl?
First, this is up.
How can first the patients? Also, you're beautiful. It's okay. And they live with you?
The first one was me and my grandma. The second one was my father. And the last one was my aunt.
Okay. They have the same fathers, all 3 of them?
Two of them, yes. Except for the last one.
Okay. I'm so sorry to hear what happened. So what did the nurses say is going to happen now?
I'm still waiting there. And yeah,
You're waiting for? What did they say? Like what did they say is the problem?
the particular, she said that I was pregnant, but the baby is no longer there. So they have to send me here to be cleaned only.
And then when you came here, what did the nurses here say?
They just gave me a vent. So I'm still waiting.
They haven't said anything, they haven't examined you or...
But they did. They did, so I don't know what's going to happen next.
Okay. All right. Thank you so much for talking to her.
Dr. Cornelian Defon speaks about the different types of abortions.
Okay, I don't want to be too medical. Broadly, we have a medical abortion and a surgical. Then medical is that you just take a tablet, you take a medicine to terminate. While surgical, there is an instrument involved in a short procedure. But any of those abortions, once they begin to have complications, we begin to give them other names medically, like incomplete abortion, where is a part of that product of conception is left inside. Then we can have septic abortion, again common with these illegal abortions because the environment where it was conducted wasn't good enough. So with the instrument I talked about, it might not even have been sterile, and then it brings in infection into the uterus, and then you get septic abortion. And you can have what they call threatening abortion, which again, if somebody has tried to terminate and it has not, should I say, it hasn't been fully effected, it's like it's coming on, and it comes to you that is a healthcare worker, you might label it as a threatening abortion. Yes. And there's also, this will go into the area of a miscarriage, which is a bit different from abortion. So broadly, you just have the surgical and the medical.
In June 2020, calls for legalizing abortion in Namibia intensified. But what are the barriers preventing reform to legalizing abortion in this country?
In places where it's restrictive, it's an absolute ban, regardless of circumstances. Whereas in Namibia, it's not an absolute ban. There are circumstances in which abortion is legal. Incest, when there's severe deformities to the child, issues of rape. So it's not one of the worst in the world.
Maria and Vicky share their experiences of the abortion methods they used to get rid of their pregnancies. Please take a look at what the two women explain.
I don't know what it is called, but I looked up for numbers, with this whole social media, and I got some numbers, advertisements. I called them and told them I was pregnant, and then they asked me how long was I, and I told them, and they said they were selling pills, and then with the period that I told them that I was pregnant for, they told me I had to pay a certain amount of money for me to get the abortion pills.
Traditional medicine.
So they had a thing in the location. I don't know. They say it's apparently a green stick. It comes. That one mostly is kata. Most of the patients, I don't know. They don't know. Most of the patients that we had mostly ended up with serious complications because of that. Because when it stays inside, it causes infection, and that infection is the one that causes either a serious sepsis or we had patients, maybe 2 or 3 cases that ended up in a uterus being removed. In someone's, it was just the first baby, then the uterus is removed. Anyway, we also had a case where someone just put a normal stick up there, and then somehow maybe it was not put in properly. It didn't go through the cervix, so it went through the meat, and then it got stuck. Now it has to come here to be removed. Those are the only 2 instances. But I think most of them are trying to find more safer methods that they can use rather than using those methods. They say a green stick. It's like a piece of a branch or thing that they take from a specific tree in the location. So maybe they buy it, or maybe they just take from any tree, then they put it up there. Maybe they have someone in the location that knows how to put it in, and then when it comes, it removes almost everything. But most of the time, it causes infection to that specific patient.
In June 2022, calls for legalizing abortion in Namibia resurfaced again and intensified to a point where a petition to amend the law to increase access to legal abortion in Namibia was signed and has attracted over 60,000 signatures. The authors of the petition proposed that the right to access legal abortion should be accompanied by education relating to sexual health and reproductive rights to prevent unwanted pregnancies and baby dumping. Attempts to liberalize the law on abortion have been met with strong opposition from religious groups and some women's groups and politicians as well. Although abortion is illegal in Namibia, in the 1 week which I visited the 2 largest hospitals in Windhoek, they record daily cases of at least 12, on some days fewer, and on other days more cases are recorded. The nurses and doctors explain further on the dangers to abortion.
And we've actually lost them, died from that severe septicemia. So what is septicemia? It's like having bacteria in your bloodstream. Yeah. And then we've also lost the ones that bled too much, particularly the surgical. Some of these people are just trying, it's like desperate to end this pregnancy. So they take instruments, they don't know the anatomy of the what we call internal reproductive organs. And then they can puncture the uterus. Puncturing the uterus can cause severe bleeding, what we call hemorrhage. And when there's a complication from illegal activity, what happens? People don't just, they're looking for corners, how to enter the health system. Before you know it, delay. And then they bring the person, we say paper white, they bled out. These are very severe cases that contribute to maternal mortality. The less severe ones, you are able to manage the infection and the girl goes home. But it has long-term sequelae after that, like blocked tubes, which if you stay alive, and I often say, which girl is not beautiful? Later, they are going to find Mr. Right. They are going to do that wedding. Then the tubes are blocked. No pregnancies. They now start to live another stage of pain. Another stage of pain completely. Then some, if they do the surgical abortion too frequently, they overdilate the cervix. Now, imagine our parents of those days could carry 9 pregnancies. The pregnancy doesn't just drop. Now, with frequent surgical abortion, they weaken the opening. So that sphincter is not there. By 5 months, miscarriage. So though the miscarriage now is natural, but the primer is the previous surgical abortions, because instruments were forcing that passage to open. You get it, oh, now nobody had that, I did an abortion. You get pregnant again, you go there, you get again, 3 times. You weaken the system.
One thing I would want to caution against always is really looking at abortion in isolation. And I think that's part of the problem with this topic. Everybody looks at it in isolation. I think once there's an unintended pregnancy and there's somebody considering an abortion, many other things went wrong. So let me be clear on one thing. Abortion doesn't resolve issues of unwanted pregnancies. Even where abortions are legal, there are unwanted pregnancies. Abortion doesn't solve the issue of reckless sexual behavior. And the reason it doesn't solve that is that it is one of many options that and solutions that should be available. It cannot be the only one. So we must talk to young people about sex. We must engage issues of sexual violence and coercion when it comes to particularly transsexual relationships. We must make family planning available. We must make contraceptives accessible to those who need them. We've got the statistics of how many young people younger than 13 years of age who are giving birth. And these statistics are uncomfortable for me. And what makes me uncomfortable is all of the tools to reduce unintended pregnancy in adolescents, whether it's sex education, whether it's contraceptives, all of these things are taboo and wrong, and against some or other religious or cultural belief system. So how exactly do we want to prevent unintended pregnancies? Because surely we're also saying we do not want teenagers to be pregnant. We know they're having sex. The only way to reduce this is to talk to young people, delaying your sexual debut, which I believe in from a health perspective. I don't think from a health perspective we should encourage young people to be having sex. We should be encouraging them to delay sexual debut. We must be able to have conversations around what's currently happening in Namibia, where abortion is illegal, where we see the statistics and we can see it's happening. A lot of these young women are looking for post-abortion care. So there's either been an inducement of a pregnancy. Our healthcare workers are dealing with this on a daily basis. So it is happening. It is a reality. We can't deny that. So to prevent us getting to that stage, because I wouldn't encourage any person to go against the law of your country, I would rather have a conversation with young people about delaying sexual debuts, around safe sex, and having frank conversations. That's really where my focus is. It's not necessarily on abortion.
Based on facts, healthcare workers, civil society, and Ms. Gengos share their opinions on restrictive religious and cultural views on abortion in Namibia.
No, I think people are free to have whatever cultural or religious view that they have. I'm not a critic of people who really believe in what they believe in. But as a Christian myself, I'm also very conscious that even in countries where abortion is legal, the moral decision of whether to perform it or not still resides with a mother. I'm not obligated to have an abortion just because it's legal in a country. So the moral decision still needs to be made. And that moral decision also needs to be made in countries where abortions aren't legal, where they continue to happen. So I would really encourage people to live by their Christian and their religious and cultural beliefs. What we should always, however, be careful of is imposing our beliefs on others, because the circumstances that require certain decisions to be made may exist outside of religious and cultural belief systems. So maybe if anything, sometimes for me, it's about health care. It's about women's health, and it's about what's best for that woman in that moment. And what's best for me may not necessarily be best for somebody else. And that's how I look at it. If something is against my religious belief system, then what it means is I shouldn't do it.